nodule, and you see here. And this is another one. This one is adnexal, benign adnexal tumor again, but this is have an apocrine differentiation. So you see one of them ecrine, one of them apocrine, but you see clinically completely different. These are large, they usually involve the scalp or forehead. Sometimes they're all boluses, and actually cover the whole surface of the, scalp. And so these can be quite, disfiguring and large. So on that next one, we're going to talk about cancer. Every time you see a papule or nodule, which is have these fairly, characteristic with these dilated or telangiectatic vessels as characteristic for basal cell carcinoma. So fairly papule with these dilated telangiectatic vessels. Most of the time comes as a, sometimes ulcerated, the problem patient in this case comes with this ulcer that never healed. And the location-wise, with the, these vessels that dilated, this is very typical for basal cell carcinoma. Now, I want to actually mention, it's not always going to be a fairly papule. Sometimes actually basal cell carcinoma, especially superficially spreading basal cell carcinoma, can be a look like eczema, can be pigmented. We're going to look at some of those pictures. So this is a basal cell carcinoma. Two things about histology of basal cell carcinoma I want you to remember. When you look at it, first of all, there are basal cells that are arising from those basal cells. So when you look at, and they are neoplastic. So when you look at it, there are lots of similarity with these cells and basal layer of the epidermis. They're, less cytoplasm, INC ratio. But two characteristics they have that very, very important for exam, as kind of always when you hear it, you think about it. One, this cleft. You see this space actually. When you see these tumor cells, this is a dermis, okay? If you consider the epidermis is here, this is the dermis, and this is a tumor here, which is invading actually to the dermis. If you look at it, actually this is the collagen. They were separated from collagen. This is space. We call it cleft. This is an artifactual. When actually we process these tissue, due to the alcohol, the soft tissue, collagen actually is, shrink. That's the reason you get these clefting. Another feature is very important. So one is this cleft, this is space. And second, when you look at the periphery of tumor, they show you these peripheral palisades. The way they are sitting, actually radially all oriented, and they're parallel. So they call it peripheral palisade. Two features. These features help you to separate a lot of other tumors, especially adnexal tumors can be very similar to this. Remember I talked about this superficially spreading? So superficially spreading basal cell carcinoma usually are not nodular, are not fairly papule. They usually are flat and they're irregular, and they show sometimes these erythematous color, scale cross. So when you see that, actually, you see these erythema, you see this scale cross, you are thinking, is this some kind of eczematous dermatitis, eczema? Sometimes actually fungal infection can show this scale cross, can show this erythema. So these are going to be differential diagnosis. Sometimes, as you see something like that, it's pigmented. So you were thinking, is this some kind of an anomaly? So superficially spreading basal cell carcinoma, differential diagnoses include infection, fungi, can be also eczema, or some can be a melanostic lesion. Now, when I say superficially spreading, how do you look at it? Superficially spreading, when you look at the normal epidermis, this is a basal cell carcinoma. So you see it's still attached to that basal layer, that epidermis. So it's not really separating and invading to the stroma like the one we saw before. But it still have a cleft, it still have a palisade. And usually they're multifocal. So you're gonna see this, there's gonna be another one here, there's gonna be another one here. So it's very multifocal and involved actually large area, but they're all superficial. The next subject is this lesion. If you look at these lesions, this is a scalp, and you can see some of these changes. It's a sun damage, so it's a balding scalp, it's sun damage. Look at these lesions, very, very poorly defined. Have these kind of, yellow tan color, and then when you look at it, have these scale cross. This is the actinic keratosis. So actinic keratosis, poorly defined scale cross with this yellow tan color, your yellow brown color. What is actinic keratosis? Actinic keratosis is a premalignant lesion, a step before squamous cell carcinoma. You all know cancer doesn't happen right away. There are a step before dysplasia. So this is that step. When you look at the skin, first of all, look at derm, sun damage. Okay, that's must here. So when you see sun damage, that's the actual cause for these actinic keratosis, and later when it becomes squamous cell carcinoma. There are sometimes inflammatory cells in the dermis, but the hallmark of this, when you look at the epidermis, I want to look at the basal layer, these area. You see these keratinocytes, they are dysplastic, they are atypical. So you see in this basal layer, in this lower part, actually you see a very atypical dysplastic keratinocyte, okay? This is not malignant because they are still confined to that epidermis. Basement membrane is intact. When they involve all thickness and break down basement membrane, become a squamous cell carcinoma. That's the step after this. So this is a premalignant lesion, actinic keratosis. Usually you're going to see increased keratine layers, so we call it hyperkeratosis, and you see some of these have a nuclei, we call it parakeratosis. These are not very important. Parakeratosis, hyperkeratosis is not specific. The hallmark is this dysplasia in basal layer, okay? Actinic keratosis. Usually sun damage, sometimes other cause can do that. One thing I forgot, basal cell carcinoma. Do not forget about the who actually predisposed to develop basal cell carcinoma. There is a list, 5 disease. So one is the kind of light pigmented skin. So somebody have an albinism, somebody have a Chilaiditi, for example. People are immunosuppressed, okay? People have some genetic problem with the DNA replication or DNA, repair, xeroderma pigmentosome. That's a very important syndrome for basal cell carcinoma. They call it basal cell Nevo syndrome. So I wanted to memorize all those 4 or 5, disease that actually put the patient in danger to develop basal cell carcinoma. So it's in the CV. So don't forget about that. So one more time, who's gonna get the basal cell carcinoma? People that have a light skin, so we know that, light pigmented skin, like somebody with Chilaiditi, even normal light pigmented person. Somebody have an albinism, okay? Immunosuppression. People have an immunosuppression, that's in danger to develop basal cell carcinoma, okay? Another one which is very important for basal cell carcinoma is the people that have some genetic abnormality that affect the DNA replication or DNA repair, like xeroderma pigmentosome. Or people have this syndrome, we call it basal cell Nevo syndrome, okay? In these, actually, in young age, they're gonna develop lots of basal cell carcinoma, and they're gonna have a tumor, for example, female ovary, they're gonna have a medulloblastoma, so it's one of the hereditary cancer syndrome, they will have a multiple. They have a cyst in the jaw, they call it odontogenic cracks. You don't need to memorize all of those, just memorize the syndrome, okay? For a small group. So, next step after actinic keratosis, squamous cell carcinoma. You look at these areas, these are all actinic keratosis. This is a cancer. This is a squamous cell carcinoma. This is an ulcerated area. And when you do biopsy, so background, sun damage skin with lots of actinic keratosis, and then squamous cell carcinoma is area that shows invasive squamous cell carcinoma in the derm. These are malignant cells, homorphic large nucleoli, and they have these squamous derm that makes the squamous cell carcinoma. As a matter of fact, you can see this is the dermis. They are invading the dermis. So invasive squamous cell carcinoma. Do not forget about the association. Sometimes HPV actually can be a cause of the squamous cell carcinoma. So sun damage certainly, but now we see more and more association with HPV, especially if the patient is immunosuppressed. So they can develop actually squamous cell carcinoma from HPV. And we're going to talk about the last case of this. So very fast, you all know about this. These are, squamous erythematous lesions. We are talking about psoriasis. So remember the color, these are well-defined, sharply demarcated. They have these white silver cross lesion. And when you look at this, before I go, just remember there are differential diagnoses. So when you see these erythematous, this erythema in the background, and when you see these scale cross that is silver white, certainly psoriasis is the first thing, which is a chronic relapse remitting lesion. But then there are other lesions can actually have a similar features. One is the eczema. Chronic eczematous lesion, dermatitis, can have a scale cross, can have an erythema. As a matter of fact, when you see erythema with these scale cross, they call it erythema squamous lesion. So these can be one psoriasis, sometimes can be eczema, and sometimes fungal infection can be like this. The differences is your CD, they're talking, for example, these are very sharply demarcated, those others are not. For example, erythema is not. Or, for example, when you look at the fungi, they usually actually, when you look at them, they're drawn, and usually periphery shows erythema or gut. Same thing, when you see histology, they call these psoriasis form epidermis or psoriasis form dermatitis. Certainly, the first thing is this the psoriasis? But as I said, sometimes actually other disease, including chronic eczema, also fungal infection, can show you the same finding. What are the findings? Take a skin, acanthosis. As a matter of fact, when you look at these retinal regions, they are all extended, and so this is the retinal regions that's extended, and they show this, club shape, and sometimes they are fused together. So these elongated retinal regions with this club shape end actually is very typical for these psoriasis form type of the epidermis. Now, how are you going to separate these three from each other? When you go to high magnification, you can separate them. In high magnification for psoriasis, in that area at the surface which you have hyperkeratosis and parakeratosis, you see collection of neutrophils. We call these Monroe's microabscess. So this, seeing this, this is psoriasis. Monroe's microabscess is a hallmark of psoriasis. As a matter of fact, you see a lot of these, we call it pustular psoriasis. So that's typical. Another feature of psoriasis is very helpful, usually granular layer, kind of, less. So you see a hypogranular, granularity. So it's a thin granular layer. But Monroe's microabscess. If this was a fungi, you start seeing fungal microorganism with a high PTM, okay? And you can do a stain. You can do PAS and show up the fungal microorganism, okay? If this was an eczema, you don't see any of these Monroe's microabscess or anything like a fungi, but what we see actually, we see something we call it spongiosis. So you see all this inside the epidermis, it's a swelling and edema, and cells actually is away from each other. They call it spongiosis. Sometimes actually you can see full of vesicles with, eczema. But main things you need to know, there are three differential diagnoses with that low magnification. When you go high magnification and you see these neutrophils, that's one. That's the psoriasis. Okay? So that's that. Another chronic lesion. This is a lichen planus. So lichen planus, you can see that 5P, we all know, polygonal, purple, purity. Remember, they can involve the mucosa. In the mucosa, they are not look like that. They're usually white and reticular, so kind of net-like. So again, both of these diseases have some immune association, this and even psoriasis. So you all know about that. We're not going to ask you that in the small group, but probably you need to know it for ME. So now histology-wise, this is very important. When you look at it, I want you to contrast lichen planus with the psoriasis. In lichen planus, again, we have a thick squamous epithelium, which is going to be the same acanthosis. But if you remember, in psoriasis, you're going to be at these elongated retinal regions. Here, actually, retinal regions here is very irregular. They call it sawtooth, irregularity of retinal regions. The reason for that is because you have inflammatory cells in the dermo-epidermal junction that these inflammatory cells attacking and destroying these basal cells. This is a hallmark of lichen planus. These inflammatory cells, which is starting this lesion, actually from dermis goes involve these basal layers, so damage these basal cells. As a matter of fact, when you look at it, sometimes there is a pocket of the damaged basal cells. When you look at them, there are